Hello. Today I would like to share with you some of my thoughts and experience related to androgenetic alopecia in men and in women. First, it is important to make the correct diagnosis. Yes, our patients often believe that the diagnosis of androgenetic alopecia can be made on the basis of the clinical appearance, but this is not always the case. I'm showing here 6 patients with hair loss that may look like androgenetic alopecia, but these are patients with trichotillomania, monolatrix, telogen effluvium, fibrosing alopecia and pattern distribution, frontal fibrosing alopecia, and senile or senescent or physiologic alopecia. Now, what is the core problem in androgenetic alopecia? We all know that androgenetic alopecia is not a disease of hair loss. It is a disease of hair miniaturization. So the hair follicle and together with the hair follicle, the hair shaft are becoming thinner and thinner and thinner and shorter and shorter and shorter. And at the very end, there are the vellus hairs that are very thin, very short, and hypopigmented. They do not contain the melanin. In real life, what we will see is that every hair is at a different stage. We will see in one field of view of a dermoscope hairs which are normal, hairs which are in the mid phase of miniaturization, and the hairs which are very thin or miniaturized, and at the end some vellus hairs. And usually the presence of more than 10% vellus hairs in the field of view, especially in the frontal area, is one of the important factors contributing to the diagnosis of androgenetic alopecia. Anyhow, the hair shaft thickness heterogeneity is one of the major in both men and women. Now, a second feature will be the presence of a decreased numbers of hair follicle units. If the majority of hair units in a patient contain only one hair, this may be indicated of androgenetic alopecia. However, also telogen effluvium may cause a similar symptom. When you take a look at these hair follicles marked in blue, there are 2 hairs in this follicle unit. This is a thick hair and a thinner hair. And the thin hair is the hair which is undergoing miniaturization. So it becomes shorter, shorter, shorter until it fully disappears, and we remain with a follicle unit with only one hair. The so-called peripilar sign. This is a tendency of the skin having a type of hyperpigmentation around the emerging hair. And it has been shown that this is associated with the presence of inflammation around the hair follicles. So in summary, the trichoscopy features of androgenetic alopecia will include hair shaft thickness heterogeneity, the presence of more than 10% of hairs which are vellus hairs in a field of view, the follicle units with only one miniaturized hair, the follicle units with only one hair, and the perifollicular pigmentation, as mentioned, a sign of ongoing inflammatory process. And in my experience, the presence of multiple hair follicles with the peripilar sign is a feature which is a poor prognostic factor. Usually patients lose a significant number of hairs within the upcoming few weeks to months. Before I proceed with the treatment, I would like to focus on the pathogenetic features which are the target for therapy if in androgenetic alopecia. First of all, this is the hair follicle itself and the changes in the hair follicle, but most importantly, the presence of dihydrotestosterone, which is inducing the hair follicle miniaturization, and up to recently it was believed that it is the only element responsible for androgenetic alopecia. And second, the inflammatory process around the hair follicle, and third, the blood vessels. The hair follicles are surrounded by multiple blood vessels, by a network of blood vessels. These blood vessels supply the hair follicle with whatever is important for the hair follicle to grow new high quality hair. So we will always try to avoid vasoconstriction in patients with androgenetic alopecia. And we all know that vasoconstriction may be caused by smoking, and especially the tobacco smoke contains, of course, nicotine, but also other substances that are very strong inducers of vasoconstriction. And it was shown that men who smoke, they will develop androgenetic alopecia at an earlier age compared to patients who do not smoke. Their alopecia is more severe, And also they're more likely to develop complications after surgery procedures related to the scalp. And this is why we recommend that patients who are undergoing hair transplantation stop smoking at least for a limited time before and after the transplantation. Now, regarding women, the data are not so robust and not so precise. It seems that in the women, this effect of smoking on the development of androgenic alopecia is not so profound. There are even some authors who claim that there is no effect of smoking on androgenic alopecia in women, but we're still waiting for new data to either confirm or not confirm this effect. There's a study I would like to show you. This is a twin study of non-smokers on the left versus smokers on the right, and it has been shown that the non-smokers tend to develop androgenic alopecia, which is less severe compared to the smokers. Now, a significant risk factor for development of androgenic alopecia and for the severity of the disease is obesity. And this is why it is important when we start treating a patient to counsel the patient in regards to the treatment of obesity. Now, when looking at the blood vessel, the main treatment option that will cause some vasodilatation is minoxidil. Minoxidil will also have other types of efficacy in androgenic alopecia, including that it will prolong the anagen phase. It may have some mild anti-androgenic effect. It may reduce the apoptosis in hair follicles, but also it may induce the production of prostaglandins, which then in turn will improve the blood flow and the growth of the hair in the hair follicle. When considering minoxidil, that is available now in our practice is a topical and the oral minoxidil. The topical is available as 2%, 5%, and now I would like to focus for a moment on the group of over 5%. Usually we think about 10 or 15 or more percent. There are some problems with this high concentration, one of them being that minoxidil is not easily soluble, so it is difficult to produce a solution which would be a good solution of minoxidil, which would be 10 or more percent. But also the other argument is that it has not been shown beyond doubt that 10 or 15% minoxidil is more effective compared to 5%. There are some data which indicate it may be more effective, but other data show that the efficacy is similar. So here we would usually stay with the 5% solution. Now, regarding oral minoxidil, in the women we would usually use 0.25 to 2.5 milligram per day, and in men 1 to 5 milligram per day. However, here the experience and the preferences of dermatologists are differing. And now there's a recent study which was showing that maybe we could use 10 milligram. However, it was not very convincing, and as the authors indicate that 17.5% patient had a significant hair improvement after this treatment. However, the number or the percentage of patients who developed adverse events was even higher. It was around 25%. So I have the feeling that we should still stay with the lower dose. The highest tolerable dose for women is usually between 2 to 3 milligram per day, and in men usually around 4 to 5, maybe slightly more milligrams per day. So in every patient we will adjust the dose according to the tolerance. Few words about the overdose of minoxidil, and there are several cases that have been published on the overdose of minoxidil, including an overdose in children, and it seems that fortunately in all these patients the adverse events were transient. Some of them required hospitalization. But it is important to mention that minoxidil can be toxic for cats especially, but also for dogs, and we should not only take care that the cat and dogs do not take the tablets that were prescribed, but also the minoxidil can be transferred to the cat via physical affection through the hand, through the hair, so we need to be careful if we have a cat or a dog at home. So this was about the blood vessel. And now I will focus on the second target of therapy. This is dihydrotestosterone, or more precisely about decreasing the conversion of testosterone to dihydrotestosterone. And the main group of treatments and medications are here the 5-alpha reductase inhibitors. There are two main approved 5-alpha reductase inhibitors: finasteride, which is reducing the dihydrotestosterone level in serum by approximately 70%. Dutasteride, it will decrease the serum level by 95%. And I would also like to mention shortly the herbal 5-alpha reductase inhibitors, especially saw palmetto. It may decrease the level of dihydrotestosterone by approximately 25 to over 30%. However, there are few significant elements which need to be taken into consideration. First, that this is not a selective anti-androgen, so it will have a wider range of activity. Also, what comes with this, it will have a wider range of possible adverse events. But I think that what is most important to take into consideration is that the herbal 5-alpha reductase inhibitors, even though they are sold without prescription, they are sold OTC, over the counter, still they do have teratogenic activity, so they should not be taken by women in childbearing age because of the risk of teratogenicity. Finasteride we usually use in women, usually 2.5 to 5 milligram. I would usually start with a lower dose of 2.5 and then I increase the dose if it is well tolerated. I increase the dose to 5 milligram. In men, as a rule, we use the 1 milligram per day. This is because there's no medical literature to show the efficacy and safety of a different dose than 1 milligram per day. Now the new product on the market is the topical finasteride in the form of spray. It may be also used. However, if we use the spray, we need to take into consideration that it is also penetrating through the skin and through the hair follicles to the bloodstream, and this will have a systemic effect. Regarding dutasteride, the usual dose is 0.5 milligram per day. These are usually capsules which contain fluid, so we cannot divide them into two or more. So we would usually use a whole tablet every day. And dutasteride is potentially available as an intralesional product for injection. However, it is not EMA or FDA approved for the injections, so unless it is produced by the pharmacy and delivered by the pharmacy, I personally prefer not to use it. However, I know that here the opinions and the literature vary. Definitely it may be effective. Now, going back for a moment to the oral form, I mentioned that it is impossible to divide the tablet or the capsule. So what many people were trying we were trying to decrease the frequency of taking the tablet. And now there's a very recent study which compares dutasteride twice per week at a dose of 0.5 milligram per tablet, 3 times per week, to finasteride 1 milligram per day. Now, as you see in this image, dutasteride 3 times per week is significantly more effective compared to twice weekly, so we should rather focus on the dose of 1 tablet per day. However, in some situations, we may decide to decrease the dose to 2 or 3 tablets per week, or to a different dose if this is the preference of the doctor and the patient. Regarding 5-alpha reductase inhibitors, finasteride and dutasteride, good to remember that the efficacy of these treatments is best in women below the age of 50 and in men below the age of 40. Of course, in older patients, we will also have some efficacy, but because the 5-alpha reductase is most active in the younger population, this is why we will have the highest efficacy of the 5-alpha reductase inhibitors in these patients. Also, in other older patients, we may have an overlap of androgenic alopecia with the so-called physiologic alopecia, and physiologic alopecia, or so-called senile alopecia, is not responding to finasteride. I mentioned already that 5-alpha reductase inhibitors are teratogenic. This is really important for women and childbearing potential because both these treatments may inhibit the development of external genitals in the male fetus. So definitely women in childbearing potential should not take or use finasteride or dutasteride. The effect of 5-alpha reductase inhibitors of finasteride and dutasteride on the breast is often a matter of discussion. However, what is important to underline that 5-alpha reductase inhibitors, especially high-dose finasteride and dutasteride, may cause breast tenderness. They may cause gynecomastia, especially in men. However, there is a huge body of evidence showing that these treatments do not cause breast cancer. I'm showing here one of the recent articles that has evaluated the possible development of breast cancer. It was a study on over 13,000 of women, and when looking at the numbers, women who were never taking finasteride or dutasteride developed breast cancer in 2.2%, and the number of patients with breast cancer in the group who were treatment with finasteride or dutasteride seems smaller. It was not statistically significant, but yes, there are some opinions which are not evidence-based that 5-alpha reductase inhibitors may have some effect in decreasing, maybe even in decreasing the risk of breast cancer. However, I would like to underline again, this is not evidence-based. However, talking about other adverse events of finasteride and dutasteride or possible adverse events of these treatments, I would like to show you a statement which was published in 2025 by the European Medicines Agency. These are the measures to minimize the risk of suicidal thoughts in patients who are taking finasteride and dutasteride. And because this is very complex, I will cite directly some of the most important sentences of this statement. First, that most patients with these possible adverse events were reported in patients who are using finasteride in the dose of 1 milligram. This is a little bit different from what we are used to see in medicine, because usually if there is an adverse event, it will increase in severity with the increased dose. So here, this is not the case. The 1 milligram seems to be most often reported. What may be difficult to explain is that these numbers seem to be lower compared to the numbers for the general population. Now finally, the statement of EMEA says finasteride and dutasteride continue to outweigh the risk for all approved uses. It has been shown in medical literature, but also confirmed by the EMEA, that there is no evidence which would link these adverse events to finasteride spray. And I may also add that the medical literature indicates that the finasteride spray does not cause sexual adverse events, which would be comparable to the adverse events which were reported for the oral form. Now, when talking about anti-androgens, spironolactone is an old medication, long forgotten for androgenic alopecia, and now there are new data which show that this may be an important tool in our hands for the treatment of androgenic alopecia. The dose is usually 25 to 200 milligrams per day. In most cases, we will start with 25 milligrams and then increase the dose. Usually, I do not increase the dose above 100. However, there are colleagues who use the 200 dose as well. Also, spironolactone may be used in the form of gel or solution, but these topical forms are not available in most countries, and they may be prepared by the pharmacy. Regarding the adverse events, they are listed on the right side. The topical form may be associated with scalp contact dermatitis, but also some patients report the smell of spironolactone in the topical form. Few words about the androgenic alopecia in children and adolescents. It seems that the frequency of androgenic alopecia in children and adolescents is increasing, and if these are very small children below the age of 6 or 7 or 8 developing androgenic alopecia, then probably they need a hormonal checkup because it may be associated with a hormonal disease. In older patients, usually there are no hormonal abnormalities. For the treatment remains a challenge. We can use minoxidil at a small dose and then increasing depending on the tolerance. However, in adolescent girls, we may also consider spironolactone in combination with minoxidil. And there is a study which was showing that there is some efficacy of this combination. When you look at this image, at least here the disease progression was stopped. This is before treatment and after 12 months of treatment. In this study, the dose which was used was 2.5 milligram of minoxidil per day and spironolactone in the dose of 50 milligram per day or twice twice daily. In my personal experience, I would usually start with a smaller dose. So now we discussed about the dihydrotestosterone and about the blood vessels, and I would like to focus for a moment on the inflammation around the hair follicle. There is an increased oxidative stress, and this may be one of the factors that contributes to the inflammation. And in patients with androgenic alopecia, we will see inflammatory infiltrates, which are superficial. And here one of the options is the use of clobetasol, topical clobetasol, and it was recommended that clobetasol may be used especially in patients who have these inflammatory infiltrates, which are manifested in trichoscopy by the peripilar sign, here in a higher magnification. If we see the peripilar sign, we may decide to use clobetasol. There are no evidence-based data to show which dosage regimen are best. Few words about dermocosmetics in the clinical practice. They may be very useful as an add-on to pharmacotherapy for the treatment of androgenic alopecia. However, in most cases, it is not sufficient to use them in monotherapy. Now, I have been showing many treatment options for androgenic alopecia and how to put them together in one patient. And there are many different recommendations by different societies and different expert groups. They do not differ between each other very significantly. I would like to share with you the newest recommendations which come from Canada. And I'll start with the recommendations for female androgenic alopecia. And the authors recommend to start as a first-line treatment with 5% minoxidil, then as a second-line treatment oral spironolactone or oral finasteride or oral dutasteride in combination with oral minoxidil, and a third-line treatment such as mentioned here in this slide. Now for men, the Canadian doctors recommend as first-line treatment 5% minoxidil foam twice daily and or oral finasteride, a second-line treatment, topical finasteride. However, you may also decide with your patient to use topical finasteride as first-line treatment. We do not have sufficient data to confirm that the efficacy of topical finasteride and oral finasteride is comparable. However, the data which are available now, they indicate that in men, 1 milligram finasteride has a similar efficacy to the topical form of finasteride. In the second-line treatment, we may add oral minoxidil and also other types of treatment as it is visible in this image. Now, to shortly summarize my presentation, the most important part of the treatment of androgenic alopecia is the correct diagnosis, and the most typical feature in trichoscopy of androgenic alopecia will be the hair shaft thickness heterogeneity. When considering the targets for therapy, we may consider treatments which target the blood vessels, in particular minoxidil, but I also mentioned that we should recommend that the patient is not smoking, and also I indicated that obesity may be a risk factor for androgenic alopecia. The second target for treatment may be the conversion of testosterone to dihydrotestosterone. AI made a minor mistake here, so this is just an illustration, not a chemical structure of this molecule. Here we use the 5-alpha reductase inhibitors such as finasteride and dutasteride. Finasteride is available in the form of tablet and in the form of spray, which may be used topically. And also, I would like to underline that also the topical spray should not be used in women who may become pregnant because of its possible teratogenic effect. And the third target may be the inflammation, and one of the methods to inhibit the inflammation is the use of topical corticosteroids. With this, I would like to thank you very much for listening until the very end. I make these videos with no commercial breaks. If you like this, please consider giving it a like. Please comment or ask questions if you like. Thank you very much.